to invite Dr. Janani because she has a presentation in next hall also. So I would like to invite her first for the presentation.
Hello. Hello. Please stick for the timing also.
But is it not listening? Please start the presentation.
Okay. Good afternoon, everyone. So the title of my study is Myopia Progression in Pediatric Age Group and its Early Prediction Using Artificial Intelligence Model. Myself, Dr. Janani Rajendran, and the chief author of my study is Dr. Jyoti Matalia. So myopia at present, the prevalence in Asia is around 60%, and it is observed more prevalent in school-going children, especially in Asia, East Asia, and Singapore. And it has become a worldwide health problem and is one of the most common ocular disorder. And progression is increased in children compared with the time before COVID-19 pandemic. And there are several studies which have shown that myopia progression may be closely related to the progressive biomechanical degradation of the sclera. So the range of progression and the stabilization of the myopia varies from one to other, which can be analyzed either using ocular response analyzer, Corvus ST, or Pentacam HR. Based on this, we conducted a study, and the purpose of our study is to predict the myopia progression in pediatric age group using corneal tomography and biomechanical parameters, and the parameters were assessed by using an artificial intelligence model. So our study, it is a retrospective cross-sectional study, 321 eyes, and the age group of the children were between 5 to 17 years with myopia, and cycloplegic refraction, Corvus ST, and Pentacam HR were carried out, and all the parameters were analyzed using orange artificial intelligence model. The exclusion criteria were children with squint or allergic eye disease, keratoconus, corneal pathology, any contact lens usage, and glaucoma were excluded. So totally 321 eyes of 321 subjects were included. The age group were 5 to 17. So we categorized them into 3 groups as group A, B, and C. So group A is between the age of 5 to 18 years, and group B is 9 to 12 years, and C is 13 to 17 years. So 5 to 18 years were totally among all those 321 eyes, 24% were in the group A and 38% in group B and C. And the myopia spherical error was in group A, that is between 5 and 8 years, the range of 0.5 to minus 12 diopters, whereas in group B it's minus 0.25 and minus 8.25 diopters, and in group C it was minus 0.25 to 7.75 diopters. So the results were, first all the eyes were further subgrouped, either there is a stable or there is any progression noted. And the manifest refraction spherical equivalence was observed, and they were grouped into myopia 1, 2, and 3, which is MRSE value of 0 to minus 3 or 3 to 6 or more than minus 6 diopters. And those eyes were further assessed. So out of this 321 eyes, we observed the progression was there in 44 eyes. And only in those eyes which has showed the progression, we did this tomographical analysis and biomechanical analysis. And the spherical refraction, axial length, and the spherical aberration were the main parameters, which is showing a significant difference. Whereas in the biomechanical parameters, spherical error again, and the intraocular pressure. This intraocular pressure was measured using Corvus ST. That also showed a significant difference. And all these parameters were assessed using this decision tree artificial intelligence classifier, which used to predict the myopia progression using artificial intelligence model. So this model, which showed us there are 3 major predictors of the progression, which are extracorneal viscosity, extracorneal stiffness, and spherical aberration. So the artificial intelligence model, which had the area under the curve of 0.73 and the accuracy rate of 0.71 and precision of 0.72. So the final discussion is, out of the 321 eyes, 44 eyes showed progression, which is 13.7%, and the progression and the statistical analysis was done only in those eyes with the severe myopia, which is myopia 3 with MRSE of more than -6 diopter, which showed the significant difference in respect to the values of axial length and spherical aberration, which was measured using the pentacam HR, and Corvus ST measured the intraocular pressure, which also showed the significant difference. So our findings showed that the children with higher the degree of myopia and longer the axial length, more pliable the cornea, which are observed in the study conducted by Lee et al. And Wong et al. And we observed one more finding, that is lower the corneal stiffness was associated in eyes with longer axial length. What does it suggest? That the higher deformation amplitude value is due to the expansion of the sclera, which resulted in the instability of the ocular tissue, and it reduced the corneal stiffness. So this study, which helped us in deepening the understanding of the myopia with respect to the age, and also it helped us mainly to predict the association of the corneal tomography and biomechanical parameters with the different grades of myopia. And myopia progression can be predicted by artificial intelligence using a non-inverse imaging data, which is obtained from Corvus ST and Pentacam HR parameters. Whereas the limitations we have in our studies are that we didn't include the questionnaires to assess any family history of myopia, or what are the outdoor activities of those children, what is their screen time. So those would have helped us to assess what are the factors which accelerated the progression. And since our study, as we have seen, 321 eyes, only 44 eyes showed the progression was seen. So a larger sample size with a long-term follow-up and equal distribution of both in a stable and refractive progression would have been helpful. I would conclude with that the significance of our study mainly lies in the projection of the tomographical and the biomechanical indices with respect to the changes in myopia and increasing age and longer axial length. But there are very few studies at present to evaluate the role of artificial intelligence in the prediction of myopia. So further longitudinal study would be helpful to understand myopia better. Thank you.
Did you compare the children who progressed with those who did not progress?
Yes, ma'am. But that artificial intelligence model, whatever the parameters, that we couldn't do. Since in our study, we included only in the eyes which showed progression. We did the retrospective of all those 321 eyes. We did what all the grades of myopia with respect to the age. That we observed in all those 321 eyes. But these parameters were assessed only in eyes which showed progression. Since it is an unequal distribution, we couldn't get the result. We couldn't apply it in all the general group. So that was the main lacking.
Anybody receiving atropine?
No, sir. Actually, the main aim of our study is mainly to intervene anything. So early prediction,
Previously nobody.
But we didn't do. In this study, we didn't do.
You said early prediction. Which age group was this prediction more higher?
It was seen more in group 3. The age group was around 11 years, ma'am. Roughly, and the age of 11 to 12 years, it is seen more. But this progression is noticed more in the myopia grade of 3, which is MRSE value of more than -6. We observed the progression more. But the age group was around 11 to 12 years.
So at 11 to 12 only you can predict further progression by AI.
That showed more progression. The rate of progression was observed more in the age group of 11 years.
That is not the time for your correction for amblyopia, whatever you need to correct it before. So what is the point of judging progression after
mainly
that?
For at least preventing the progression further. Early intervention with sir as asked for the atropine. So that would have been helpful if you predicted. As I told, there is a limitation of the questionnaire. So if you would have included all those things, early intervention, and the data is what we have shown, only 13.7% had the progression. So all those other eyes, maybe the age group would have been different. But in this, only 11 years was the mean age. But with a larger sample size, maybe that would have changed.
And the other thing was corneal stiffness, you said. So did you check for the family history? I mean, corneal stiffness may be abnormal in those families also.
That we didn't check that. Since it's an initial study, we would like to apply in a larger sample size with all the family members included. Thank you, everyone.
Thank you.
Yes.
Now I would like to call the next speaker, Dr. Neetu Thanam. You can start with your presentation.
So good afternoon, all the delegates present on and off the dais. My topic for pre-paper is visual rehabilitation and quality of life with corneoscleral lens in patients with irregular astigmatism. So I have no financial disclosure. So the rehabilitation of patients with irregular astigmatism is challenging, and it was previously done with lenses such as rigid gas permeable contact lens and later rose-scale lenses. But however, corneas with higher keratometric values, these lenses are not very well tolerated, hence scleral and corneoscleral lenses came into use. So, as far as scleral lens is concerned, its peculiarities are it is made up of a rigid gas permeable material, and it is designed to vault over the irregular cornea. And as you can see in this picture, it holds a liquid reservoir of non-preserved saline, and it lands on the sclera, and it has got an optic transition and a landing zone. And in this video, you can see how the liquid reservoir converts an irregular corneal surface to a regular surface by maintaining a fluid reservoir over it and provides a sharper vision by neutralizing the astigmatism. So credits to the Silverline laboratories for the videos. So my aim of the study is to assess the visual acuity achieved with corneoscleral contact lens in patients with irregular astigmatism, and my primary objective is to assess the improvement in visual acuity and the number of visits taken for the correct fit of the corneoscleral lens, and my secondary objective was to assess the quality of life with a standard questionnaire, the click questionnaire, and to record the complication with the lens use. So my materials and methods, it was a prospective interventional study conducted in 32 AIOC2023 patients for a period of 1 year from July 2021 to July 2022 in a tertiary eye care center, and my study population include those with corneal ectasias and post-LASIK ectasias and post-keratoplasty patients with irregular astigmatism. According to the following formula, my sample size calculated was 31, and an informed consent was taken, followed by a detailed ophthalmological evaluation, which include refraction, keratometry, tomography, and the contact lens fitting. So coming to the contact lens fitting, so after the patient thorough ophthalmological evaluation, we select the first trial lens based on the cornea profile, following which the fitting evaluation was done. So we check for the central fitting as well as a peripheral fitting. In central fitting, as discussed earlier, there was a non-preserved saline mixed with sodium fluorescein. That's how we check for the vault of the lens. So if the tear reservoir is less, we steepen the base curve, and if it's high, we flatten the base curve. As well as we also check for the peripheral fitting by looking how the lens lands on the sclera. If there is movement, we reduce the landing zone, and if there is impingement, we increase the landing zone. So once both fittings are acceptable, we do over the lens refraction and convert as per vertex conversion table. And after the lens removal, if there is any conjunctival staining, it's not acceptable. Finally, we add the converted power to the trial lens power, and the order is placed. So this is a video again how we see for the central fit. And the central, this is actually the green strip is a fluorescent mixed with a saline. That's how we check for the vault. Ideally, it should be around 300 micron, but it can vary according to the corneal profile. So there should be not too much of reservoir when it becomes highly vaulted, or not too less, which can cause a corneal apical touch. Then this is a picture showing the correct lens insertion. That is a peripheral fitting of the lens. There will be no blanching of the conjunctiva, whereas if there is an incorrect lens insertion, there will be conjunctival blanching. So this is a lens from Silverline Laboratories we have used in our study, which had a diameter of 14.5 mm. So a full day trial was done, and multiple trial was done, and once the fit is confirmed, we order the lens. And we also record the number of visits to achieve the correct fit, and we give the contact lens impact and quality of life questionnaire on patient on day 1 month and 6 months to be filled. That's how we measure the patient satisfaction. And we also recorded the mean comfortable wear time. And these are my results. So the age range was around 50 to 60 years, and 69% of the patients were females. And in my study, the majority of patients had keratoconus. Around 69% of the patients had keratoconus. And the number of visits, around 75% of the patient nearly took 2 visits to achieve a correct fit. Then when we see the association between the average central keratometry and the number of visits, those with a mean of 60.76 nearly took 3 visits, which showed that higher keratometric values increase the number of the visit to achieve the get the correct fit. And when we see the best corrected visual acuity with corneoscleral lenses, it came to 0.14 compared to the mean baseline best corrected visual acuity of 0.5. And in our study, 85% of the patients had no complications. And when we see the mean click cross score and the person measure, it was statistically significant between day 1 month and 6 months of follow-up. So coming to the discussion, so multiple modes of visual rehabilitation are proposed to manage corneal ectasias causing irregular astigmatism, and corneoscleral lens seems to be an effective option. So our study showed the statistically significant improvement in visual acuity, and also the one patient with an average central chetometry above 70 diopter was tolerating the corneoscleral lens. This indicates that it was a feasible option for patients even with higher keratometric values. And the mean comfortable wear time was around 10.3, the range of 7 to 12 hours, and the average total score obtained on day 1 and the end of 6 months also showed a positive correlation. This indicated that the patient was satisfied with the use of the lens at the end of 6 months. So to conclude, to the best of our knowledge, no previous studies have assessed the fitting, complication, and patient satisfaction with corneoscleral lens in patients having irregular astigmatism in a sample population in India. And our result states that the use of corneoscleral contact lens will be an effective option, providing a good visual acuity and an optimum visual quality in patients with irregular astigmatism. And the limitation of my study was a smaller sample size and a short-term follow-up. And these are my references.
Did you compare this study with rigid gas permeable lenses? Or?
No, sir, we didn't compare the study. We just
the comfort with RGP lenses and this,
no comparison was done, sir. We initially gave a trial of corneoscleral lenses in those patients.
What is the cost of these lenses?
It is 17,000, ma'am, for one lens. So it can be used up to a period of 4 years. If it's maintained well, if the patient comes in between visits, we can polish the lens, and up to 4 years, the patient can use his lens.
So you want to ask something?
Did you do Schirmer's test and vascularization after 6 months? Did you look for it?
Schirmer's test, no, ma'am. But we were assessing the tear breakup time with the fluorescein, but we didn't do the Schirmer's test.
The breakup time was normal.
Yeah, it was normal, ma'am.
So, next speaker is Dr. Prerna Shetty.
Good afternoon. I'm Dr. Prerna Shetty, and I'll be presenting a paper on antifungal reservoir in Boston side scleral contact lens for treatment of fungal keratitis. The other co-authors were Dr. Shushank Balarao, Dr. Uma Thigale, and Dr. Pratik Gogri. I have no financial interest to disclose. As we know that infectious keratitis refers to inflammation caused by pathogens in the corneal tissue, and they can be bacteria, fungi, viruses, and protozoans. About 11 to 47% of infections are caused by fungus across South India. In general, keratitis is difficult to treat because intraocular drug penetration is partially obstructed by the impermeability of strong defensive barriers of the eye. Because of the short residence time of conventional eye drops, and frequent installation of eye drops is necessary to maintain high levels of topical drugs for a prolonged time, especially in severe cases. So one potential option to get the prolonged exposure of antimicrobial drugs could be using the scleral contact lens with an antimicrobial reservoir. The indications for scleral contact lens, that is the large diameter lens, is usually for corneal ectasia, where the conventional contact lens fails to give an adequate vision as well as comfort. And also it is used in other ocular surface diseases where the lens is filled with preserved saline, which acts as a tear reservoir. The purpose of our study was to report the outcomes of using Boston side scleral contact lens with an antifungal reservoir as a therapeutic approach for fungal keratitis, and to discuss the clinical potential for this treatment of this treatment modality in future to treat fungal keratitis. It was a prospective consecutive case series study conducted at the Kode Venkatadri Chowdhury campus of LV Prasad at Vijayawada, and the approval from the Institute of Ethics was taken, and it adhered to the tenets of Declaration of Helsinki. It was done during between the time period of February to July 2022, included the patient diagnosed with fungal keratitis on microbiological examination, whereas it excluded cases which were clinically herpetic keratitis, high-risk corneal perforation, allergy to topical antifungals, and pregnancy. Blunting of feathery edges, reepithelialization, and reduction in the antechamber reaction were considered as a response to therapy. So what was done is a scleral contact lens of 8.5 millimeter diameter was filled with 1% voriconazole, and anterior segment OCT was used to measure the scleral lens vault in every patient. To avoid corneal touch during the overnight use, the the haptic was steepened using the Fit Connect software. Follow-up period was scheduled on day 1, day 3, 1 week, 15 days, and 1 month. And if the infection showed any signs of resolution, then the wearing time of the scleral lens was reduced to only waking hour duration. So the standardized protocol which was used in the study was to use the contact lens 24 hours per day until complete reepithelialization is achieved or there is any signs of resolution. Whereas in such cases, the wearing time was reduced only for waking hours. Daily removal of scleral contact lens for cleaning, disinfection with classic multipurpose solution Boston Simplest was done, and refilling of the reservoir with voriconazole when needed. Adjuvant treatment consisted of using oral ketoconazole medication. Slit lamp photography and anterior segment OCT were used in subsequent follow-ups to record the resolving infections. Statistical significance was determined by simple mean, percentage, and frequency tests. Average age of the patient was 41.66 years, ranging from 37 to 47 years, which had 2 male and 1 female subjects. Average size of the ulcer was 3.25 millimeters, ranging from 1 to 4 millimeter. The resolution period of each patient was different based on the size, and the larger the ulcers took more time to resolve. All 3 had a peripheral infiltrate, and one out of these 3 had a hypopyon. Average duration of resolution was 18.7 days, ranging from 7 to 27 days. ASOCT also showed resolution and stromal scarring post-lens wear. So the main outcome was the resolution days, which was reduced to 7 to 27 days in our study. These are some pictures showing the pre and post usage of the scleral contact lenses in 2 of our patients. The main limitation was the cost in our study for the scleral lens and the ability of lens and the trained personnel to train the patients. And the loss of BCL was also one of the concern. And voriconazole 1% was used instead of the recommended natamycin 5% as the primary drug. And the risk of secondary infection was one of the limitation. And a larger study group for better assessment of the outcomes, that is a controlled randomized clinic trial with larger number of patients to compare scleral lens reservoir treatment versus antifungal drop treatment could be performed. To summarize, Boston site scleral contact lens with an antifungal reservoir is an effective therapeutic approach for fungal keratitis and could be an alternative in the management of fungal keratitis. Because of the comfortable treatment for the patient, it ensures a good impregnation and maintains the antifungal concentrations throughout 24-hour wear periods. The rate of healing is also increased using scleral contact lens with the antifungal reservoir, where we saw it was from 7 to 27 days, where topical medications in the previous literature showed 12 to 16 weeks for resolution. Thank you.
Samples I was 3.
Yeah, we had just 3
patients.
Yes.
Okay. And did the medicines were with this preservative or without?
They were preservative-free voriconazole. Preservative-free. That's why we could not use natamate because it caused whitish discoloration.
In these 3 cases, did you encounter any secondary infection?
No, doctor. No skin infections.
Actually, debridement is one of the treatments. No, when you put a contact lens, you cannot do that. So how actually can you compare just 3 cases and say that is better than the usual conventional treatment?
Yeah, that's why the samples, that was one of our limitation as the sample size. And
I mean, how would you recommend a contact lens over routine treatment in just a 3 millimeter? It's just a normal fungal ulcer.
Yeah, we wanted to start with the smaller ulcers to see how it responds. Then we wanted to go ahead with the larger ulcers. Thank you.
The next speaker, Dr. Jay Oswal. He's not.
No mark.
For him. Ratified. It's written.
Yes. No.
You are not a ratified member, so we will not be judging you.
Good afternoon, everyone. I'm Dr. Jay Oswal. I'm a second year DNB resident. My topic for today is comparison of the refractive error measurement using streak retinoscopy, auto refractometer, and a gimbal scope. I have no financial disclosure. Starting off with the introduction. Retinoscopy is an objective refraction technique and is extremely important in the complete ocular examination of a patient. It is a subjective method and is highly dependent on the skill of the patient and the skill of the ophthalmologist and the optometrist performing it. Despite the presence of amazing literatures and animated videos, we have no real-time actual videos of the retinoscopic reflex. We searched online and we found Dr. P. Chandrakant et al. Has published a study which has used the gimbal scope as a setup to in which he's connected a smartphone to the retinoscope and recorded the retinoscopic reflex. So in this study, we plan to using the gimbal scope, comparing it to the autorefractometer as well as the streak retinoscope to check how accurate and how effective it is. Coming to the objectives. The first objective is to evaluate the accuracy and effectiveness of refraction using the gimbal scope, and the second one is to determine whether the retinoscopic reflex obtained via the gimbal scope is similar to that of a streak retinoscope. Materials and methods. So in this study, we used a smartphone. We use a smartphone mount holder with bracket clamps. We use a smartphone holder clamps, rubber bands, a retinoscope, and a handheld refractometer, as you can see in the images. For the methods, this study included 300 eyes of 150 children and adolescents. Refractive measurements were obtained using the gimbal scope, streak retinoscope, and the auto refractometer. The spherical, cylindrical, and the axis values were obtained from all three devices, and spherical equivalent was calculated for a single value, so it can be easy to compare. And it was statistically correlated. Study description. This trial took place at Arvind Eye Hospital, Coimbatore, in the Department of Pediatric Oncology, and it was a randomized prospective hospital-based study. Over a period of 6 months, included 300 eyes of 150 patients. Males were 56%, females were 44%. The mean age was 11.47 years and median was 12. Males were 83, females were 67. Right and left eye were in equal proportions. Coming to the results. We saw that the mean spherical equivalent of the streak retinoscope and the gimbal scope was equal, which was minus 1.48, and that compared to the auto refractometer was minus 2.20. The median was 1.62, minus 1.62, and 2.25 respectively. Now, from these basic descriptive statistics of data, we found that there exists a highly positive, statistical significant correlation between the streak retinoscope and the gimbal scope. Discussion. Now, smartphone has reformed ophthalmology in the past few years. They have become an asset in the ophthalmic teaching and for recording and storing images. As a postgraduate, retinoscopy is an extremely difficult technique to learn and even difficult technique to master. The incorporation of smartphones has eliminated this difficulty. In this study, we have compared the gimbal scope to the retinoscope, to the streak retinoscope and the auto refractometer to evaluate its accuracy. Now, I'll be showing you a few videos. Now this is how we make the gimbal scope. So you can see the smartphone holder clamped and the bracket clamp being connected via corkscrew. To this, we have used two bracket clamps connected via rubber band and sellotape. Now to this we will attach the retinoscope. So the retinoscope has been fixed to the entire setup. So now due to time constraints, I could not add the further video. The smartphone goes in one of the bracket clamps with the camera orienting towards the the optical piece of the retinoscope. Here are a few reflexes recorded. The first one is against the rule astigmatism, against the rule reflex, sorry. This is via this has been recorded through the gimbal scope. So you can see neutralization being performed here. This is the scissor reflex in a patient of keratoconus. And this is with the rule reflex. So our study is not without its limitations. The whole setup of the gimbal scope compared to that of a streak retinoscope is extremely bulky to use. It could also be difficult to use a dial behind the retinoscope to adjust the slit width. Also, there's a short learning curve involved in aligning the smartphone to the retinoscope. Now coming to the conclusion. So the study shows that gimbal scope can be used as a reliable teaching tool for viewing and recording retinoscopy reflex with observer and mentor in real time. Now this will especially be beneficial for postgraduates who find it difficult to learn this technique and master it. And that's the reference of the study we found on the retinoscope by Dr. P. Chandrakant et al.
A very good afternoon and a warm welcome to all. I'm Dr. Harpriya Sahu and I'll be delivering a talk on evaluation of wavefront aberrations in myopic patients in a tertiary healthcare center. My mentor and chief author for the study are Dr. Ashok Madan sir, Dr. Rajesh Joshi sir, Department of Ophthalmology, Government Medical College, Nagpur. Well, myopia is one of the leading causes of visual impairment globally. Like any optical system, the eyes suffer from failure to conform to the mode of ideal image formation. This is called as aberration. The human eye is an imperfect optical system wherein wavefront aberrations blur the retinal image and therefore reduce the contrast sensitivity and visual acuity. As per various studies, third and fourth order higher order aberrations contribute to maximum higher order aberrations in human eye. Aim of my study was to evaluate these wavefront aberrations in various categories of myopia and take into account these differences so as to plan our resources for betterment of visual outcome. This was a cross-sectional observational study including 210 eyes of 105 myopic patients equally divided into 3 groups, low, moderate and high myopia, and commonly found higher order aberrations, that is coma, trefoil, spherical, total ocular and total corneal aberrations were considered in a 6 mm natural pupil in mesopic light conditions. Method used was Hartmann-Shack wavefront analyzer, that is eye design machine, and Scheimpflug camera with Placido disc topographer, serious topographer. Myopes as per definition with age more than 18 years with astigmatism of less than equal to 1.5 diopters in both eyes with best corrected vision of 6.6 were included in this study, whereas patients with other ocular conditions including strabismus, any systemic disease, past ocular surgical history, small pupil and history of use of contact lens were excluded in the study. So, commonly found higher order aberrations were considered in different grades of myopia and the mean age was around 25 years with female preponderance. The mean overall period for gradual progressive diminution of vision as well as spectacle use was around 10 years. My study shows a positive family history with mean cycloplegic refraction and keratometric values which differed significantly across various grades of myopia. The difference in mean corneal aberration, that is coma specifically, was statistically insignificant. However, the difference in mean corneal trefoil and spherical, the difference was statistically significant across 3 groups. The difference in mean total coma and trefoil ocular aberrations were statistically insignificant. However, the difference in mean total fourth order spherical aberrations were statistically significant. Both the RMS, both for corneal as well as total ocular aberrations, differed insignificantly across 3 groups. We considered patients between age group of 18 to 40 years, and this study, as I already mentioned, shows female preponderance with positive family history. The most predominant corneal higher order aberrations were coma aberrations, which changed insignificantly with increasing severity of myopia. Corneal third order trefoil aberration decreased significantly between moderate to high myopic groups, whereas spherical aberrations decreased significantly between low to high myopic groups. Among all total ocular higher order aberrations, third order trefoil ocular aberrations remains the most predominant total ocular aberrations. This falls in line with the studies conducted by Prakash G. et al. In 2008 and Nakano et al. If we compare both these studies, we find that normative data between Indians and Asians overall were different. So there was an insignificant decrease in total ocular trefoil aberration noted with increasing severity of myopia. Also, with increasing severity of myopia, the amount of total ocular third order coma aberrations decreased but changed insignificantly. A study conducted by D.A. Atchison et al. In 2006 found no trend in coma with a change in refractive error, which falls in line with another study carried out by Artel et al. In 2006. Total ocular spherical aberrations significantly increased with increasing severity, whereas our study showed that total corneal and ocular RMS decreased insignificantly. Corneal HOA RMS were greater than RMS of total ocular higher order aberrations. Also, all higher order aberrations decrease insignificantly with increased severity except for trefoil third order and spherical fourth order corneal aberrations, which decreased significantly, and total fourth order spherical aberrations, which increased significantly. So, it was observed that majority of myopes had a similar amount of aberration as emetropes. Also, emetropic children had more aberrations as compared to emetropic adults, which goes against the direction of causality and progression. To conclude with, myopia in our study was found to be more prevalent among females with a positive family history, which justifies the fact that heredity may play an important role in occurrence of myopia. Age distribution in our study was limited to minimize the effect of age on our aberration measurement. Overall, it was observed that the third order trefoil higher order aberrations remain the most predominant total ocular higher order aberrations, and third order coma corneal higher order aberrations was found to be most predominant corneal higher order aberrations in central India, as it was carried out in central India. The fourth order spherical total ocular aberrations increased significantly among three groups of myopia. This knowledge can be used efficiently while correcting aberrations through surgical procedures like refractive surgeries. This will improve visual performance significantly. Amount of corneal aberrations were much higher than the total ocular aberrations, which explains various internal mechanisms that play a role in compensating corneal aberrations. All higher order aberrations included in our study changed insignificantly with increasing severity of myopia. Our observations therefore provide no evidence to support the idea that HOAs in humans have a large impact on emetropization or progression. Limitations were ideally this study had to be a longitudinal study so that we could have got a better result, but this was a cross-sectional study. Also, we focused on higher order aberrations among young adult populations only. Studies need to be carried out to evaluate the same in various age groups. These were my references. Thank you.
Would like to ask something now?
You said there are internal mechanisms to compensate. What internal mechanisms are you talking about?
Ma'am, there are many natural internal mechanisms which compensate these the blurring of vision which are caused by these aberrations, such as the peripheral rays which are cut off by iris. Like the retina is less sensitive to the peripheral retina is less sensitive to the rays of light, and also there's something like the retina is more sensitive to perpendicular rays as compared to ocular rays. Also, the center, the nucleus of the lens is more dense as compared to the cortex. So that also helps in reducing the aberrations. I'm talking about specifically the spherical aberrations and the commonly found aberrations.
So in these patients, did you look at the grading of the lens? Because one of the important thing is...
Yeah, ma'am, we considered patients within age group of 18 to 40. So most of them were like, all of them were like with clear lens only. So this is one more loophole. Yeah.
And you said that children have most aberrations, but in this study we did not include any children.
No, ma'am. That's what I said. That's a limitation in my study. Yeah.
Okay, thank you.
Thank you.
Now I would like to call Dr. Afreen Bari for her presentation.
Good afternoon, everyone. I am Dr. Afreen Bari, and I will be presenting on natural wavefront aberrations of Indian eyes using ray tracing technology. There are no financial disclosures. Second order aberrations are spherical and cylindrical refractive errors of defocus and astigmatism, which can easily be quantified and corrected. However, wavefront aberrations of third or higher radial order, considered as higher order aberrations, are difficult to measure and correct, and they are primarily caused by corneal as well as internal factors. And there are other factors as well which play a role, like age, pupil size, accommodation, lighting conditions, which will affect the higher order aberrations. It is difficult to measure the wavefront aberrations using subjective methods, as it will depend on the subject's judgment. There are various modern wavefront sensors which have been used for objectification. Most commonly used method was Hartmann-Shack wavefront sensor. However, in our study, we have used the recent advanced ray tracing technology, which works on the principle that various rays are given to the human eye, and their projection on the retina is checked at what point they are projecting, as seen in this figure. The various modalities are Snell ratio, point spread function, which is the image of point object through the optical system. It is a necessary component for the retinal image construction. Modular transfer function is another important aspect, which is basically the amplitude, which basically tells us the amplitude of image that the patient perceives in terms of sinusoidal gratings. We reviewed the literature. We saw that there was limited data in literature about the normal data. There is no normal wavefront data on higher order aberrations in Indian eyes. With the same, we planned a study to investigate the natural wavefront aberrations using ray tracing technology and establish normal data for the same. It was a cross-sectional observational study at API Center, AIIMS, and all cases which fitted the inclusion and exclusion criteria were included. There were total 600 eyes over the duration of 12 months. We included cases between the age group of 18 to 30 years and emetropic patients, that is on tracy refraction if it was within plus minus 0.25. All cases with any ocular or systemic comorbidities were excluded. Any cases of dry eye disease were excluded. Tear breakup time and Chummer tests were done to rule out these. And any patient with history of any cosmetic contact lenses, they were also excluded from the study. All cases underwent ray tracing aberrometry with music pupils and accommodation at rest. The distance target at 6 meters was given. The results were, the mean age was 25.4 years, and most of the patients were emetropic, so the logMAR uncorrected visual acuity was 0.02. The spherical refractive error was also 0.13. Keratometry was within the normal range, and the mesopic pupil size was around 5 and photopic was around 3. The results of higher order aberration were, the total higher order aberrations at the pupil size of 3 and 5 were at 3 there was 0.076, while at 5 it was 0.22. And this was the corneal as well as the internal of the total differentiation of the total higher order aberration. Among the third order aberrations, which was basically the coma and trefoil, it was again quantified, and the mean was taken out at 3 mm and at 5 mm. The total coma at 3 was 0.042, while at 5 was 0.152. If we take the trefoil value, it was lesser than coma, it was 0.137, while at 3 mm pupil it was 0.046. We also calculated the fourth order aberrations, basically the spherical aberrations as well as secondary astigmatism. These were lesser than the third order aberrations, the total being 0.047 at 5 mm pupil and 0.012 at 3 mm pupil, and the secondary astigmatism total being 0.06 and 0.01. Again, we also quantified the point spread function at 3 and 5 mm pupil. We saw that at 3 mm it was 0.5, whereas at 5 mm it was 0.16. The MTF was also calculated. The mean value was calculated for the total as well as corneal and internal parameters, and it was a graph was made for the modulation transfer function. Coming to the summary, this is basically the study for the establishing the normative data. Human eye has various higher order aberrations. Despite these, one does not necessarily perceive all these symptoms of glares and halos. The ray tracing aberrometry eye trace is a useful tool to analyze and quantify the ocular aberrations. It is a quick to use and easy OPD tool which can be done in OPD patients. Aberrations increase with increase in pupil size, and both cornea and lens contribute equally to total higher order aberrations in our study, in which the age group was limited to young patients. Coma was the dominant higher order aberration in our study. Through this study, we aim to establish the baseline normative higher order aberrations for Indian eyes. This will help us to pick up the abnormal values from the other data. Thus, eye trace may aid as a good preoperative tool for candidates willing for premium IOLs and refractive surgery. To conclude, quantifying natural wavefront aberrations helps in better understanding of the optical quality, and this may have a role in future. Through artificial intelligence, it can be attached to the software, and we can be able to understand whether the aberration is high or low. And customization through customized contact lenses and customized refractive surgery can be planned in future. The limitations of my study are that it has a fixed age group of inclusion criteria. The children and elderly patients were not included, and we have just included the normal patients. However, other pathologies can also be taken, and it can be compared to the normal like keratoconus. Thank you.
Good afternoon all. I'm Dr. Mamta Raghavar, and the topic for today is relationship between stereopsis and experimentally induced astigmatism. I have no conflict of interest to declare and no financial disclosure. Stereopsis is a measure of depth perception by brain on receiving two slightly dissimilar virtual stimuli. It can be affected by various factors like age, refractive error, amblyopia, anisometropia, strabismus, etc. It begins to develop at 3 months of age and is usually completed by 6 to 7 years of age. The prerequisites for stereopsis are large binocular overlap of the visual fields, partial desiccation of the afferent visual fibers, and the coordinated conjugate eye movements. The normal visual acuity is around 40 to 60 seconds of arc or better. Coming to astigmatism, it is a state of emetropia in which the refractive error varies in different meridians. Different axes and types of astigmatism have a varied effect on stereopsis, which has been studied here. Coming to the objectives of the study, to analyze the effect of different axes of astigmatism on stereopsis, and to study the effect of type of astigmatism on stereopsis. It was a cross-sectional study that was done in 300 subjects. The statistical analysis was done using SPSS software 20.0. Coming to the eligibility criteria, all the emetropes between 10 to 40 years of age having normal stereopsis of 40 to 60 seconds of arc were included. Patients with any ocular pathology such as cataract, glaucoma, amblyopia, squint were excluded from the study. Critically ill and unwilling patients were not included. A cross-sectional study was conducted amongst 300 individuals who came for a general checkup in ophthalmology department over a period of 1 year. The study was conducted after taking ethical approval from the institute and the informed consent from the individual. Distance stereopsis was then measured using the new Fresby-Davis distance stereo test at 0, 45 and 90 degree after inducing an astigmatism of -1, -2, +1, +2 cylindrical power, and then findings were recorded. Similarly, the near stereopsis was measured using the Titmus stereo test. An interval of 10 minutes was given between each test to avoid any eye fatigue. This is an image showing the new Fresby-Davis distance stereo test. In this 4 different images, the 4 different objects are mounted on a rod and placed in a square compartment. One of these objects is placed a little anterior, that is a little higher arc as compared to the rest of the 3. The patient is then asked which object appears closer, and accordingly the stereopsis is measured. This test can be carried out at 3 different distances, that is 3 meters, 4 meters, and 6 meters. At 6 meters, there is a chance of monoocular clue. To avoid the same, the test is done in 2 different steps. First we take the binocular stereopsis and then the monoocular stereopsis. If the result of the monoocular stereopsis is better than the binocular one, then we understand that the monoocular clue have played a picture. If it is same, then the test is inconclusive. To get the accurate result, the binocular stereopsis should be better than the monoocular one. The next is the Titmus stereo test. In here, the near stereopsis was measured. We used a polarized glasses for the same to maintain a disparity between the 2 eyes. There are 3 parts of this test, that is the fly test, the circle test, and the animal test. In each square, 1 circle is a little elevated, and in each row, 1 animal is a little elevated. The patient needs to say which one is elevated, and accordingly, the stereopsis is measured. These were the results. At distance stereopsis at 0, 45 and 90 degree, it was noted that the deterioration of stereopsis happens when there is an increase in the dioptic power of astigmatism. It was also noted that the distance stereopsis is least affected at -1 cylindrical power and most affected at the +2 cylindrical power. Similarly, at near stereopsis, at 0, 45 and 90 degree, it was noted that deterioration of stereopsis happens when there is increase in the dioptric power. But here it was noted that it is least affected at +1 cylindrical power and most affected at -2 cylindrical power. These are the two graphs comparing the distant and the near stereopsis at the 4 different dioptric powers and the 3 different axes. It can be seen in the graph that the axis which is most affected is the oblique axis, 45 degrees, and the least affected is 0 degree. Discussion. Stereopsis is necessary for the visual-manual coordination and fine precise tasks. Stereopsis can be measured using various tests like Titmus, TNO, Lang, Presby, random dot stereo test. A gross estimation of depth perception beyond 6 meters is made due to the monoocular clues such as motion paradox, linear perspective, overlay of the contours, distribution highlights and shadows, size of the known objects, and the aerial perspective. Astigmatism creates a blur image which leads to deterioration in the stereo acuity. Blurring of the image is proportional to the dioptric power of astigmatism, and thus the stereo acuity decreases with increase in the dioptric power of astigmatism in both myopia and hypermetropia. In hypermetropia, since the near vision is affected already, the binocular-induced hypermetropic astigmatism causes a greater deterioration in near stereo acuity as compared to the binocularly induced myopic astigmatism that has a better near vision. What is unique about this study? According to our research, we didn't come across any study which has measured distant stereopsis in relation to astigmatism. Limitations. The study was done in normal individuals who were not adapted to any blur image or disparity. Thus, a gross reduction in stereo acuity would have been noted. Effect of astigmatism on stereopsis might be more if it was present since the early childhood, which could not be assessed in this study. These were my references. Thank you.
Good afternoon, everyone. Today, I am here to make you understand what is the importance of knowing white to white and how it plays an important role in topographical interpretation. I have no financial interest. External scleral sulcus point, it's the transition point of the opaque sclera to transparent cornea. The distance between the boundary points of this external scleral sulcus along any specific corneal meridian is nothing but your corneal white to white. So, we have many methods to measure this corneal white to white. However, all the methods are quite time consuming and they are cumbersome. However, topographers can measure this white to white in most of the meridians. So previously in reported literature, they have evaluated this white to white with an assumption of this external scleral sulcus as an elliptical shape, and they have measured only in the horizontal meridian, and they have commented. And in pentacam HR, usually it measures in one meridian using its low resolution NFAS camera. However, we also have another camera which is of high resolution, that is Scheimpflug camera. Using densitometry, we can still measure this white to white in all 360-degree meridians. So with this background, we wanted to define this white to white using Scheimpflug images and the morphometric analysis of the same using a custom-built program which was linked to Pentacam. Those children aged above 5 years who attended the pediatric OPD for glass checkup were considered for the study, and all underwent Pentacam in an undilated state. So once Pentacam was done, their image was selected and the white to white software was initialized. Once that was initialized, it will take you to Scheimpflug image. There we do inversion of the image where your sclera will appear black and the transparent cornea usually appears white. So once we take the measurement in all the 25 meridians, the data would be presented on the sheet that is plotted on a graph. So this would give you the location of the white to white in most of your meridians. So here, the steep axis in the topography is around 77.8 degree. And the same way, the location of the minimum white to white is around 80 degree. So both are agreeing with each other. So just the extension of the video, once we take the data from the anterior corneal edge, this is the densitometry graph which is showing you the transition from sclera to cornea. 0 is your sclera and cornea is 256, which is the transparency. This jump in the graph is usually represented as a peak here. This, our scientists have done operation called mathematical differentiation, and we get this graph, and the distance between two peaks gives you the white to white. So the digital caliper in the software is going to measure the white to white between these two peaks, and then the data is plotted on the graph. So 353 eyes of 350 patient was analyzed, and some example where I want to show that the location of the white to white is correlating with the topographic steep axis. This here you can see the minimum white to white is located at 67.7 degree, whereas here it is 66.3 degree, almost around 1.1 diopter difference. Here it is around 88 degree, here 83.4 degree, here the same way 106.4 degree, here 107.5 degree. So both are agreeing with each other. So if you look at the percentage error in distribution of the data, when we plot the topographic axis with the axis which is determined by your location of white to white, most of the data is distributed around 0. So if you look at the percentage error in commenting this would be around 7 to 10 diopter was present in around 83% of the data. In the same way, the keratometry value less than 1 diopter error was seen in 76% of the data. So looking at this, if you look at a normal topography, the bad value is not abnormal, it is normal. When you look at a keratoconic eye, the bad scoring is abnormal because there is abnormality in the elevation as well as the curvature map. But if you look at a normal cornea with a low white to white, with a smaller white to white, you can still get an abnormal bad score. So the hypothesis we want to propose is those who have a low white to white, nature would does an compensatory steepening mechanism for the corneal curvature, but it doesn't necessarily mean that there are weak corneas. So corneal diameter usually develops at birth, it is around 80% of its size, which continues to grow, and usually it grows up to 4 years of age. After the growth of the diameter is usually minimal. Hence, the age range what we have included in our study is after 5 years. To achieve the emetropization of the eye, there will be increase in the corneal diameter along with your axial length. At the same way, there will be decrease in your corneal curvature along with your lens power. So the refractive status of the eyeball is dependent on your axial length, corneal curvature and lens. Since the white to white also develops along with the structural elements of other parts of the eye, we should consider this parameter also in commenting on the refractive status. So with this, I would like to conclude that when you are deciding for a refractive surgery, if somebody has a steep cornea, always look at white to white. It doesn't necessarily mean that they are a weak cornea, and you can still go ahead with the refractive surgery because these patients we have followed up for up till 3 to 4 years and we did not see any change in the topographic parameters. And you can also make it whether it is a true keratoconus or a false keratoconus. Because the white to white influences your K value, you can also use it in phakic sizing and cataract in IOL power calculation. However, the limitation of our study was, though our study parameters were very reliable, Pentacam we did was a 25 scan protocol. There is also another option which is available in the Pentacam with a 50 scan protocol. Theoretically, it will improve the accuracy of our results, and we can also include a larger sample size in multi-ethnic groups and other irregular corneas. So to conclude, we knew that white to white corneal diameter and corneal curvature were considered to be an independent variables. But our study shows that white to white could have a direct influence on curvature of the cornea, thus contributing to refractive status of the eye, and it can locate the position of the topographic steep axis. And I would like to acknowledge my scientists for the data.
Your white to white was minimum at 67 degree. What was that?
Yeah, when we analyzed wherever the position of minimum white to white is there, that is correlating with the topographic steep axis.
Yeah, that is at 67.
Yes,
so that is an area which we usually don't measure, no? When we take even the steep axis, we don't measure at that area. 67 is your. So what is the value in this study of yours?
See, we have analyzed so many. That's what, madam. In all the previous studies, they have analyzed in one meridian and they don't take it into account. White to white differs in every meridian, and what we know is horizontal meridian is wider compared to vertical meridian. Actually, with our study, we have seen that vertical white to white need not be minimal. It can be minimal even in the other meridians. No, so that position would always correlate with your astigmatism in the topography.
So now you are suggesting that we should look at the 67 part.
Yes, in every meridian you need to look at the position of minimum white to white, will give you the astigmatism axis.
last presenter, Dr. Mithun.
Respected chair and delegates, wish you all a very good afternoon. I would like to thank AIOC Scientific Committee for giving me this opportunity. So today's my talk is on corneal tomography in fellow eyes of unilateral keratoconus for early detection of subclinical keratoconus. So I have no financial interest. Studies in literature suggest that subclinical or clinical keratoconus is found in 1 to 6% of the myopic patients undergoing refractive surgery. So as we all know, advanced keratoconus can be diagnosed with typical biomicroscopic, retinoscopic and topographic findings. However, detection of the disease in the preclinical stage is challenging. As you can see in this pictorial representation, the terminologies keratoconus suspect, form frusi keratoconus and subclinical keratoconus. Most of the time when we see the literature, these terminologies might be overlapping. So this gives a comparatively better picture which shows that a subclinical keratoconus includes both form frusi and keratoconus suspect, and this white vertical line is the topographic cutoff, which shows whatever goes above that is significant or suggestive of keratoconus. So form frusi keratoconus usually defined as the contralateral eye or the fellow eye of a patient with keratoconus, which is an incomplete or distorted form with subtle topographic changes or without any topographic changes at all. Whereas keratoconus suspect mostly comes with some topographic changes, although in both these terminologies the slit lamp appearance might be normal. So basically it is very difficult to diagnose a case of form frusi keratoconus, which can be either false negative also. So the purpose of the study was to analyze the topographic and tomographic changes in fellow eyes of unilateral keratoconus by comparing them with normal eyes. Because in literature what it says is, if unilateral keratoconus is diagnosed, then the fellow eye is believed to have subclinical keratoconus. So it could be the ideal model for the earliest form of subclinical keratoconus. That's why we have chosen unilateral keratoconus patients. So this was a 5-year retrospective observational comparative case study. Patients with unilateral keratoconus diagnosed by pentacam and normal refractive surgery candidates were included. So we have divided the study subjects into 3 groups. First one was advanced keratoconus eyes of unilateral keratoconus patients. Then group 2, that is the fellow eye of unilateral keratoconus patients, and the third group was a normal group with 34 eyes of normal refractive surgery candidates. And how this study differs from the studies in literature is that in here we have considered the fellow eyes as completely normal, that is even with the final d value less than 1.6 standard deviation without any changes. So the exclusion criteria include a history of ocular surgery, trauma, or any ocular pathology and significant corneal scarring that might potentially affect the outcomes. So topographic and tomographic examinations were performed using a pentacam, and data from all the maps, that is topographic, elevation, topometric and bad maps, were analyzed. These were the statistical methods used. I have used a chi-square test followed by a one-way ANOVA test to compare between the groups, and an ROC curve was plotted, and those parameters with the area under curve more than 0.7 were considered as significant with diagnostic specificity and sensitivity. So 64 eyes of 49 patients were retrospectively analyzed altogether. In that, the advanced keratoconus manifested more in left eyes, and the ratio of male to female patient was 2:1, which was similar in literature. Mean age was 26 in the unilateral group and 25 in the normal group, which was not significantly different. So these were the 5 parameters which actually showed significant differences between the fellow eye and the normal group. That is the corneal thickness at the apex, the thinnest point of the cornea, corneal volume, bad thinnest point and thinnest point displacement. So I plotted an ROC curve, and as we had a lot of tables due to the paucity of time, I could show only this curve. So these were the 4 parameters with the area under curve more than 0.7 with good sensitivity. But however, you can see the specificity is very less, which means there can be a false positive also. So the D value, DT, DA, that is D thinnest point displacement, and pachymetric progression index maximum. These were the 4 parameters which were found to be affected at the very earliest stage of keratoconus. So D value and PI max were the most characteristic indices. These two were similar to studies done by Vasquez et al. And Husseini et al., but those studies were done in a different demographic population. The present study is the first study to identify the early changes in Indian population in fellow eyes of unilateral keratoconus patients. So the limitations include a small sample size because as we all know, the incidence of a true unilateral keratoconus is very rare. Like in this study, we have included only those where the fellow eyes are absolutely normal with less than 1.6 bad D index. So it is unlikely to skew the results of the study. However, further studies with larger sample size and simultaneous evaluation of the newer technologies, that is the corneal biomechanics and wavefront aberrations, may be more useful because here we have used only pentacam parameters. So to conclude, bad D value and pachymetric progression index were more effective than other pentacam parameters in detecting the earliest form of subclinical keratoconus, and the study also supports the usefulness of sham film imaging to assess subclinical keratoconus. However, any single parameter alone is not enough to detect the changes. We need a combination of different data to distinguish subclinical keratoconus. Thank you.
In this study, 3 groups were taken. The patients with keratoconus were also taken, and the fellow eye and the normal eyes.
Yes, ma'am. So we had 3 groups. One was like patients with unilateral keratoconus. So the eye with keratoconus is group 1, and the eye of the fellow eye is group 2, and normal candidates. Normal candidates means those who have undergone either a SMILE or LASIK with no changes of ectasia for 6 months follow-up.
So you could have compared group 2 with group 3 directly.
We have compared, ma'am.
Yeah.
So this is basically we have compared all different groups because there were a lot of tabulated columns, so that's why we didn't show it. Actually, we have compared all the comparisons between group 1, group 2, group 2, group 3, group 1, group 3. All the comparisons were made. So basically it was between the normal eyes and the fellow eyes, basic comparison.
Main comparison was.
Yes, ma'am.